Hi there. Today we're going to be talking about vehicle extrication and less about the technical aspect of vehicle extrication, the actual cutting, and more about the most important part of vehicle extrication or vehicle rescue, which is the patient or patients. We're going to cover some basic patient care premise with you. We're going to talk about how to get set up for success to keep from creating additional patients from your rescuers and the heat in Texas as well. So with that, I'm going to go ahead and take this camera from our videographer here, and we're going to move over and I'm going to show you a couple of things. First off, we want to have a charged hose line down on the ground, and that's already pulled off our rescue unit. We're going to simulate that and show you these guys getting off here in a sec. But at the very minimum, a dry chem extinguisher, because we never know about the possibility of ignition. What we set up for you today is an offset head-on collision, one of the most fatal types of wrecks we can have. We have a patient simulation in here too. We're going to take a quick look at some of the stuff we have on the ground also. And just like we let off talking about heat, be sure you guys are hydrated. We're all going to be in full protective gear. And this goes for anything we're doing anything in the summer. As you can see, we got our tools set up for success on a tarp. This is actually a mega mover, a patient care tarp. We'd use a little bit larger tarp. One thing I want to point out on here, in addition to the tools, is a pin in pack. One of the things we miss on patients sometimes is the chance of actually creating more injury with them. And so we actually have a pack for our vehicle rescue that has hearing protection, eye protection, respiratory protection, because of course the cut glass, and a blanket to cover that patient with. The vehicle's already stabilized, and again, this is for simulation purposes only. And with that, we're gonna go ahead and pan over to our crew, who's just arriving on scene of this wreck.
All right, so engine 61's on scene. We're looking to see if the scene is safe, and we're checking in with any other first responders or any other ICs that are on the scene at this point to assess where we need to start out at. So we're making entry to the car, and we're checking on the patient and verifying if the patient is alert and oriented at this point. Sir, are you okay? Are you oriented? Are you awake?
Where am I?
Okay, so the patient is talking to us. We're looking for assessment as far as he's communicating with us. He's also breathing at this point, but we're looking for, is there any type of uncontrolled bleeding, hemorrhaging? We would check all that at that point. We'd also look to see if he's having any airway difficulties, if he has any traumatic injuries to his chest or anything like that. If we could open the door, or the door's already open, we would come in, and we'd also look if there's any impingement that we need to take care of that the fire department needs to start working on. At this point, since he's communicating, I would move to the back, and I would stable his C-spine.
What happened? Where am I?
Okay.
Help me.
I'm going to hold your neck so you won't move anymore. You're gonna communicate with us, but I do not want you nodding your head up or down.
Yes, sir.
You understand?
Yes, yeah.
All right. You get in and hold that collar, put that collar on for me.
I'm obviously taking a little video license here. It may or may not be this easy to hop in the other side of the vehicle. In our particular situation that we're recreating, this side of the vehicle compartment was not accessible either. So the only place the professional rescuer could actually enter the vehicle would have been from the back. So I'm going to sit here and just provide some commentary on what Tony's doing, and he and I are going to have some discussions on what he's doing. So Tony, so we know that taking C-spine early is important. I think we've all been trained to do that. This is my opinion, y'all, but my opinion is that if your victim can cooperate with you, once you place the C-collar, you may not have the manpower resources to sit there and have someone hold C-spine the entire time. You can properly place the C-collar, you can instruct them on the importance of not moving their head, and then you may need to actually go ahead and do some other things. There's all kinds of things you can do as well. You can even use tape or whatever to actually secure their head to the seat, kind of like you would on a backboard or a stretcher. So, if you don't have enough available rescuers, do that, use that to your advantage. Sometimes there's not enough room in a wrecked vehicle for more than one person. So, and we'll go ahead and simulate, Mark's outside, he's going to go ahead and simulate assisting Tony with getting that collar put on.
again, everything's harder when you have on extrication or structural gloves. So, you know, be cognizant of how rough you're being with your patient. Be as gentle as you can. Okay. And then, Tony, what are some basic things that you like to do when you come up on a patient like this? What's your general trauma size up that you like to do?
Generally,
there you go. I'm gonna help you with your.
Generally, I'd like to look around and make sure if there's any obvious hemorrhaging coming when I first walk up. Also assessing, is there any type of respiratory distress that needs to be managed? As far as, sir, if you keep your hand down while we're doing this, thank you. If there's any type of obvious respiratory distress or any type of trauma to the chest, to the face that we need to, assess at that point.
Right, you know, we talk about that a couple of the most important steps right away are to get a general impression. So, our class, we talked a little bit about coming in, like you just said, and evaluating their work of breathing to decide if you have a respiratory issue to begin with. And also remember, circulation-wise, it's easy to come in and just grab a radial pulse. Remember, that tells you a lot about what their blood pressure is and then also what their heart rate is. And we're doing that, you're estimating at that point, right, Tony?
Correct.
Okay, great. All right, so we're going to say that he's going to be cooperative and help maintain his own C-spine here so that you can do some other things. So in our class, we kind of talked about the 4 major killers of trauma, right? So we talked about it being, of course, hemorrhage or hemorrhagic shock. We talked about loss of the airway. We talked about obstructive shock, like a tension pneumothorax, and then we talked about uncontrolled hemorrhage. So in this particular case, Tony, how would you, he's pretty stuck in here like Chuck, right? That's what your nickname's going to be during this, is stuck like Chuck, okay? Tony, how would you assess him for any significant hemorrhage at this point? You're going to have to get kind of creative, right?
Either from the back, I'm moving down and going from the top to the bottom, and I'm looking to see if there's any obvious bleeding that would be coming from the clothing or any type of wetness that would be on the body that would make me think that there's some type of bleeding that is going. I'd also be asking the patient, does he have pain in certain areas that I need to focus on?
And then, Mark, just because you're outside, I know you're extricating, right? But Tony can also ask you quickly, since you can sort of reach in over the window, or if you already have the door popped, you can go ahead and finish palpating his abdomen, legs, the pelvis, stuff like that, just to make sure that there's no significant hemorrhage. And then, of course, if we have significant hemorrhage, what are we going to do?
We're going to apply pressure to it and with a bandage to start out with and hold pressure on it, and then we're going to secure it as best we can in the position that he's in at this point.
Well, and you got some other work to do, right? I mean, you have other things you want to get to. So guys, if you have if this patient is this sick and you have uncontrolled hemorrhage, if it's on an extremity, just place a tourniquet. We'll come back to that in a little bit, right? If it's somewhere in the abdomen, pelvis, junctional area, then let's pack it, right? That's a great time. Grab your combat gauze, like you said, Tony. Get it packed, get it dressed, and get that bleeding stopped. Okay, very good. Well, at this point, he's awake and he's talking to us. So what other information would you like? Would you like some actual vital sign information?
Yes, we'd want to do we did a quick vital check when we did the pulse check to see what kind of blood pressure he had there, but we're also looking at, what is his respiratory status at this point? What is his oxygen saturation level at this point? Also, what is his blood pressure doing? Because we need a baseline to start out with to know if he's trending up or down in his vitals.
So do you want your extrication team to pass you a cardiac monitor?
Correct.
All right.
One thing to note here too, as they're getting everything prepared, is that this is a training environment, so sometimes it's a little bit hard to simulate the drama of the situation. A lot of times these patients will be in extreme distress and crying out in pain or in fear. But we want to do everything we can to talk to the patient, talk their way through it, let them know, hey, I'm in here in the vehicle with you. I'm going to take good care of you. We're going to take really good care of you. We're going to get you out of here as quickly as possible, and we're going to get your injuries treated. It can also be particularly emotional if there's been a fatality that they're already aware of in the same vehicle. or if they've had a patient's been injured that's already been removed from the vehicle and they're wondering what happened to them. And we want to keep the emphasis on, we're going to take good care of you. We're never going to lie to our patient. We're going to be very honest about what's taking place, but this is a good time as these guys are getting set up where our primary rescuer or another person assigned to patient care would be covering that with the patient.
So it's really hot, and so we're taking some liberty here with some things. Obviously, you know, we don't have the sticky dots on the EKG and everything else, but what we want to demonstrate here is that Tony does have room back here for his cardiac monitor. Okay, stop it, sir. And he's able to get a blood pressure cuff on the patient. We're able to get pulse oximetry on him. Tony, if you wanted to, could you even get an end-tidal CO2 cannula on him?
I could put a nasal cannula on him and get the end-tidal CO2.
You have access to do all those things, absolutely. And this is another thing, you know, it might be hard for you to get, like, you know, the lower trunk leads. You know, this is why your team needs to have some awareness of all the medical equipment. Even if you're the person doing the extrication, you still can help your inside medic do that stuff. All right, and so, you know, at this point, we've got a few things done. You've got initial trauma assessment, you've got C-spine, you've got bleeding control done, okay? And Tony, even though you're doing a really good job, he's not doing so hot. So our patient, we've noticed over the last few minutes, is becoming less and less responsive, right? And you've been doing a great job. You've been watching his SATs, you've been watching his CAP-NOS, so you've even been looking at a real-time readout of his respiratory rate, and you're noticing actually that his respiratory rate is starting to become slower. And so what are your thoughts on airway management at this point?
At airway I'd be checking with the other members on the team. Can we get him out of the vehicle now? Or are they still working on getting him extricated? If we can get him out of the vehicle, we want to get him out of the vehicle. If we can't get him out of the vehicle, then we have to start looking at, can we breathe for the patient at where they're at right now? If they can't breathe, then we have to look at advanced airways.
So in this particular situation, and Tony, I think you said something really important. Guys, if you're the inside medical person, you have to be updating the outside extrication team on what you're seeing, because y'all all know this. If you've extricated for a while, you know there's a precise way that takes a little more time, and there's a little bit of a sloppy way that's faster, right? But sometimes we have to make those decisions based on what's happening with a patient. So, you know, Tony, I agree with you 100%. You got to be telling these guys, hey, we're not doing so hot, guys. We need to go as fast as we can. But sometimes it is what it is. You know, the extrication that there was the other day, there was just no opportunity to get him out faster. So what would you want to do? Let's say that, you know, are you going to try and intubate this guy like this? Or would you think maybe you might use an eye-gel? Or?
I would use an eye-gel. Eye-gel would be much easier at this point. But the other thing that I'd want to look at, is it something that is in his chest that's causing him not to breathe? Is it something that we need to do a needle decompression, or is it something actually we just need to breathe for the patient? So I would go with an eye gel.
Okay. And then would you want to change his, like if you had the opportunity, would you want to position him differently or anything?
I'd want to position him differently, or I would like to lay back the seat if the seat would lay back.
Okay, all right. And that's an interesting point. You know, we all know that sometimes, not always, we know sometimes the car still has power, right? We know sometimes the battery hasn't been disengaged yet. So if it's a power seat, sometimes you can take advantage of those controls and you can actually lean it back. Or in this particular case, I believe this vehicle is a manual seat. So again, you're going to work with your extrication team and say, hey, can you guys get that seat back a little bit?
And that's an important point right there too with the electrical. A lot of times we should be cutting that battery, obviously, to make it safer from an ignition standpoint. We want to be sure before we move in to cut that battery that we've done things like move the seat and take any action that the vehicle may need before we disconnect power to it.
Absolutely.
And
So,
one of the,
go
I was
ahead,
going to make a comment also, since we think that he does have some type of trauma that goes with this would be more of the jaw lift move to open that jaw up instead of tilting that head back.
And if that fails, would we go ahead and do the head tilt chin lift if the jaw lift isn't successful?
No, we would not lift that chin.
Well, I think you're going to have the opportunity that if you're not able to use, you know, C-spine stable type things, which they are effective, then we would look at using an advanced airway to hold it open, right? Okay.
Yes.
All right. Tony, you mentioned something really interesting. So you talked about if he has...
I think you made the point.
Okay, I'm sorry, sir.
So our patient says a jaw thrust is not comfortable. Thank you, patient. See, he's becoming more alert. Good job.
Yes.
You know, Tony, and it's not going to be great, but if you suspected a tension pneumothorax, if you're feeling or seeing tracheal deviation, JVD, you know, you can actually even, you know, granted it's going to be loud because we're going to have tools. You could even try an auscultate. you actually are in a position where you could do a chest decompression if you had to.
Correct.
Right? And even, you know, you might have to, this is obviously a police vehicle. It's got this mounted right here for holding the shotguns. But if this wasn't here, you could even slide around, and you could probably actually even do a finger thoracostomy if you had to, or whatever. Okay. So next question is, at some point, you know, we're not going to save this guy's life with IV fluids, right?
Correct.
But if at some point you may need vascular access, right? Now, whether that's maybe to give him a little pain medicine or whatever's safe for the situation. Where you are right now, Tony, what would you do to get vascular access? Let's say he's not really very conscious anymore.
If he's not very conscious, I certainly could look at the neck. Also could look at the upper arm at this point for IVs. And it depends on what the protocols at this point, but I certainly could get in the brachial region. I could get in the upper arm very easily.
Okay. And then you could even, you know, how long have you been a paramedic, Tony?
Oh, 20 plus years.
So, you know, I would argue, guys, that there's a little bit of an old school and a new school, right? I mean, you know, back when we trained, we didn't have a lot of the nifty new devices and stuff that they do, right?
Correct.
But I mean, you know, you're even looking, you can even actually get to his hand, actually.
Correct.
You know, so you could try and do a peripheral IV.
And even here, hear me that hand over there.
Sure.
Because over here, I mean, just pulling this hand back here, I have access going in the hand right here.
Right. But now let's say, I mean, maybe he's in shock, right? So let's say that you're not seeing anything peripherally that you can stick. What else can you do where you are right now? More of a new school technique.
As far as IVs?
Yeah, could you do
Oh, I could do an IO into his shoulder.
Absolutely.
Yeah.
And in this guy, something that we're talking about is we think he may have a lot of pelvic and lower extremity trauma, right? So we know that we're probably not going to look for an IO site in the legs because, again, we think we've got significant vascular damage to the legs. But if his upper body looks pretty good, right, if that proximal humerus and everything else looks pretty good, you've got access to one or both of his shoulders. You could actually do one or two humeral IOs.
Correct.
Okay. All right. You know, and the reason for that is multiple. Again, if we have somebody that's hemodynamically doing really well in terms of their blood pressure and everything, but they're in a lot of pain, we could give them some pain medicine. The other thing would be, in a lot of our long extrications, we're going to have aircraft there, right? And so remember what your aircraft brings to your scene. In most cases, they're bringing you blood products. So again, communicating with your flight crew outside, explaining what's going on with the patient's vital signs, and together making a determination if it's time to go ahead and start infusing some blood products to buy more time for the situation.
And that flight team would also come in with advanced airways. If you don't have the advanced airway technique or technicians there, they could do that.
All right, well, you know, I think we've talked about some basic techniques. I think one of the most important things that we've demonstrated here is it's important to go ahead and try and get a rescuer into the vehicle. You know, again, Tony's in all of his protective gear. He's wearing appropriate stuff. And, you know, and it's safe in this case for him to get in the vehicle. So, you know, challenge yourself. How can we provide the best care possible for the patient where they are? Again, focus on the things that hurt the patient: loss of airway, uncontrolled hemorrhage, obstructive shock from a pneumothorax, and again, what's the fourth one that I'm forgetting? I'm having heat stroke in here. I don't know what it is, but loss of loss of your airway. Okay. So, you know, you dealt with all those things. You did a quick rapid trauma assessment. You stopped the bleeding. You stabilized his spine. You did airway interventions. You got your monitoring equipment on him. We established vascular access, and, you know, we can move forward with care and treatment from that point.
And I think a big point in all of this is that you have to be communicating with your patient the whole time, because you're going to see the patient deteriorating faster with, you know, if they started out communicating with you, they're not being coherent anymore, they're not communicating, you need to focus on that. You also need to focus on the team that you're working with on the extrication, on where are they with getting the door off, what are they doing to, you know, get the legs free, and how fast can we get out of the vehicle.
So in closing, I want to thank the crew from Rescue 61, Dr. Taylor Ratcliff, who's also a captain with our department. We have a firefighter, Tony Woodard, Specialist Wilkerson on the videography, firefighter Vassaw's inside. The other thing I want to bring to your attention is, obviously we're here, we're by the lake, we're by our community center. We've got a nice lit environment, albeit very hot. things don't always happen like this. In fact, things rarely happen like this. It's usually on the side of the road, it's dark, it's in a ditch, conditions aren't very good for what we're trying to do. Be set up for success. We talked about the ignition stuff early on, having a hose line, having a fire extinguisher down at the very least. Your pin impact to try and keep patients from being more injured as we extricate them. Getting patients out of the vehicle and away from the vehicle, doing your triage, especially when it's 104 degrees outside, or even people on the side of the road we may need to put into one of our apparatus or ambulance just to keep them cool so we don't end up with some heat-related illness. The other thing we can do, what you saw today was the medical team. We need to branch this out early on into groups. We need to divide it out where you have somebody in charge, he gets off as an incident commander. We need to have a medical group, and that's what you saw today is the medical group's focus is taking care of the patient. A rescue group, and those are the folks on the tools, and their entire focus is on communicating with the medical group and getting the patient out as quickly and safely as possible. And last but certainly not least, a traffic control group to make sure that we don't become a fatality statistic on the side of the road. I thank you guys for joining us today. I hope this has been beneficial for you. For those of you with Morgan's Point, you can refer back to our SOG A110 vehicle rescue for more information on this. And thank you guys. Be safe out there. Take care of your patients. Take care of yourself. Unfortunately.
He was kind of combative.